Hello everyone, my name is Srisharan Vituri. I'm a PhD student in the Mechanical and Aerospace Engineering Department at the University at Buffalo, and I'd like to give a brief overview of my poster, which explores using 3D mapping of vessel wall enhancement for robust risk stratification of intracranial aneurysms. To give a brief introduction about the problem I'm trying to address, intracranial aneurysms are these weak bulging spots formed on the vessels of your brain vasculature as shown over here. And if left untreated, some of these can eventually grow and rupture, which can cause permanent disability or even death. However, the risk of rupture of these aneurysms is very low. It turns out only 1.5% of these, approximately over a 1 year period of time, ever actually grow and rupture, and this percentage is 3.4% over a 5 year per period of time. But this does not mean that the doctors treat all the aneurysms they come across, because the treatment itself has risks too. It turns out endovascular treatment has a 4.7% chance of a poor outcome, or a surgical treatment has a 6.7% chance of a poor outcome, where the patient has to come back for retreatment eventually. So it is absolutely critical to identify only those aneurysms which need treatment and avoid treatment for all the others. The nature of these intracranial aneurysms is such that these are incidentally or and discovered and are very asymptomatic. And there are multiple imaging modalities out there that can be used to diagnose intracranial aneurysms. A few of the commonly used imaging modalities are CTA, MRA, and MRI imaging. Now, once an aneurysm is discovered on these images, it is crucial that to identify which aneurysms you want to treat and which ones you want to observe on follow-up imaging. The current clinical practice is that they make this decision based on the size of the aneurysm at the time of imaging. But this in itself has problems as well, because size measurement is done on 2D image slices, and this can be very subjective as shown on the figure on the right. To address this problem, recently a phenomenon called vessel wall enhancement has emerged as a potential solution. Herein, the doctors take a baseline MRI image of the aneurysm called the non-enhanced MRI image, inject a gadolinium-based contrast, and take up a follow-up MRI image called the contrast-enhanced MRI image. And if the gadolinium-based contrast is absorbed by the aneurysm wall in some form and proportion, this case is said to be positive, demonstrate positive vessel wall enhancement. Now, the interesting part is that this phenomenon has been correlated with unstable aneurysms or growing aneurysms in multiple studies in the past. And the major advantage is that this minimally invasive clinical imaging biomarker. The problem with this, however, is that again, it's similar to size, it's very subjective. So the vessel wall enhancement as a phenomenon is broadly classified into two different types. There is circumferential enhancement and there is focal enhancement. Circumferential enhancement is a case where there is uniform absorption of contrast throughout the aneurysm wall, as you can see over in this figure. And focal enhancement is that specific parts of the aneurysm absorb more contrast as compared to other parts of the aneurysm. And these two different types have different clinical implications. For example, focal enhancement has been correlated more towards the presence of intraluminal thrombus, and circumferential has been correlated with the presence of vasovasorum in the aneurysm wall. And both of these have clinical implications towards the treatment decision and the treatment modality itself. So the objective of our current study is we want to assess the variability among clinicians in grading the type of vessel wall enhancement in different cases, as well as the presence of wall enhancement. Moreover, we also want to use our existing 3D mapping pipeline to map this vessel wall enhancement, which we observe in 2D, into 3D space and quantify this using first order metrics, and use these different metrics to build logistic regression models and hopefully try to identify if there is presence of enhancement, and if there is, the type of enhancement in that specific case. Moving on, for this specific study, we used a cohort of 35 intracranial aneurysms, and we asked 3 different trained clinicians to mark for the presence as well as the type of vessel wall enhancement. Following this, we asked an expert radiologist with 13 years of experience to mark all these cases on the presence as well as the type of wall enhancement that he can observe. And this is what we used as the gold standard or the true label for all of our 35 cases. Following this, we evaluated the agreement amongst all these 3 clinicians on the presence as well as the type of vessel wall enhancement. And after that, we used 3D mapping pipeline to map this 3D vessel wall enhancement intensity onto the aneurysm sac. And then we quantify it using 10 different first order metrics, following which we build logistic regression models for first to assess the presence of vessel wall enhancement and a separate logistic regression to assess the type of vessel wall enhancement if there is enhancement present. Moving on to the results, I want to talk a little bit about the variability amongst the clinicians first. We observed that overall in these 35 cases, the clinicians tend to agree on the presence of vessel wall enhancement in only 75% of the cases approximately, and they agree on only 54% of the cases on the type of enhancement, whether it's for circumferential or focal. The accuracy measures the accuracy of each individual clinician with the expert rater, and you can see that overall there is an 80% accuracy on an average for all the clinicians. However, this accuracy reduces, excuse me, in the in assessing the type of vessel wall enhancement. Furthermore, we actually segregated these into small aneurysms and large aneurysms, and we observe that in small aneurysms particularly, the agreement is even lower. It's 69% for the presence of vessel wall enhancement and 52% for the type of vessel wall enhancement. But this changes when you look at larger aneurysms because the agreement increases where the clinicians agree on the presence of enhancement on all the aneurysm cases, and they agree on 67% of the cases on the type of vessel wall enhancement. But interestingly, we observe that each individual clinician has different accuracies for rating the type of vessel wall enhancement because the aneurysm region itself is pretty large, and different clinicians can look at different parts of the aneurysms or different slices on this 2D on the 2D slices and have a different response for the type of vessel wall enhancement being exhibited. So following this, we used a 3D mapping tool to map the vessel wall enhancement intensity onto the aneurysm sac as shown on the figure over here, and we plot a histogram and define 10 different first order metrics as shown over as listed over here. And it turns out that 8 of these 10 first order metrics are significantly different between aneurysms exhibiting enhancement and aneurysms having no enhancement. And in the aneurysms exhibiting enhancement, we find that none of these 10 features were significantly different between circumferential and focal, well, primarily because we only had 13 cases for the second analysis. To get into the details of this mapping a little bit more, this has been published previously by our group. But to briefly explain it, we use MRA image, which is positive contrast in the lumen, to segment the aneurysm sac, and then we use 3D interpolation to to map the registered vessel wall enhancement MRI image onto this segmented sac. Moving on, we build logistic regression models separately for for identifying the presence of enhancement, and then a separate logistic regression model to identify the type of vessel wall enhancement. First of all, to graphically demonstrate uh, the importance of these 10 first order metrics, we perform principal component analysis. And we can see in this PCA plot there are three different clusters, one which is formed for circumferential enhancement, one for focal, and one for the non-enhancing IA groups. And we can see that clearly there are different clusters which can be formed. Hence, we can expect good performance from our models. The figure on the right over here demonstrates the receiver operating characteristics of all these different logistic regression models. We can see that the area under the curve of the ROC for the vessel wall enhancement presence detecting logistic regression model is 0.94, which is very high, and it is 0.78 for the logistic regression model identifying the type of enhancement. Again, there were only 13 cases with vessel wall enhancement. Hence, you see the AUC is relatively lower compared to the other logistic regression model. But given large enough cohort, we believe that this can be further improved using our existing pipeline. Furthermore, we also performed Shapley analysis, which is a multivariate analysis, which shows you which of the input parameters had the maximum impact on the output prediction. And it turns out in identifying the presence of enhancement, the maximum range, median, and average intensity over the entire and mapped SAC have the maximum impact on the prediction. And furthermore, we also see that the median and average have the maximum impact when identifying the type of enhancement. So to conclude, we observe that 3D mapping can assist in robust quantification of vessel wall enhancement and also reduce variability among clinicians. We also showed that metrics obtained from our 3D mapping pipeline can also be used for risk stratification of IAs and prediction of presence as well as type of vessel wall enhancement. Future studies can explore using this pipeline and these models to study on larger cohorts and use aneurysm rupture as the label. Thank you.